mi misión es dar paso a la siguiente mesa. Yo no la voy a moderar, la va a moderar dos personas de muchísimo valor, y quiero subrayarlas. Quiero mencionar al doctor Calles, que es un oncólogo que en unos pocos años, ¿no? Ha tenido una ascendencia y toda una trayectoria muy relevante. Es una persona muy estudiosa, es muy inteligente, está trabajando mucho en muchos ensayos clínicos y está pues ahí en el Gregorio Marañón trabajando mucho y estando presente en muchísimas reuniones nacionales e internacionales. Muchísimas gracias, Antonio. Antonio, junto con, y lo estoy dejando en segundo lugar, es profesor con el doctor Rafael Rosell, va a ser el segundo moderador o el comoderador, lo va a hacer también en streaming. No ha podido venir a Madrid. Rafael es un jubilado muy especial porque trabaja más que antes. Rafael Rosell, pues ¿qué vamos a decir de Rafael Rosell? Rafael Rosell creó el Grupo Español de Cáncer de Pulmón. Rafael Rosell creó una línea de trabajo basada en la evidencia, en la internacionalización y la exigencia máxima, y nos introdujo a un buen número de oncólogos en esto tan raro de la apoptosis y de los genes, que nos sonaba en aquellos años de finales de los 90 a cosas raras, ¿no? Rafa Rosell sigue investigando. Nosotros tenemos un par de proyectos en colaboración con él, por ejemplo, y Rafa Rosell, pues aparte de sus innumerabilísimas publicaciones, es una persona inmensamente respetada en el mundo internacional. Yo quiero expresarle también mi profundo respeto como colega, pero sobre todo me gustaría que se me considerase como alumno suyo, que perteneciente a su escala. Así que, Antonio, te dejo a los mandos de esta pequeña nave y al doctor Rosell, que supongo que estará ella enganchado, ¿verdad?
Imagino que podremos ver al profesor Rosell, ¿no?, en la pantalla para poder codirigir. Para mí, quería agradecer, Carlos, tus amables palabras a la Fundación ECO por hacer esta reunión y la oportunidad de estar con el profesor Rosell empezando esta primera sesión general. Es muy importante que revisemos los avances terapéuticos que ha habido con la inmunoterapia en cáncer de pulmón. No en vano es la primera sesión por eso. Y para revisar estos aspectos tan complejos de la inmunoterapia, cómo posicionar los tratamientos, tenemos un listado de ponentes internacionales excepcional, que nos van a hablar de diferentes aspectos de la inmunoterapia en el cáncer de pulmón. En una primera presentación hablaremos sobre las combinaciones de los puntos de control inmunológico en primera línea. Para ello estará el doctor Jordi Remón revisando la evidencia científica en este respecto. En una segunda presentación nos focalizaremos más en ese subgrupo especial de pacientes que tienen una alta expresión de PDL1 en el tumor. Para eso el profesor Jürgen Wolf nos hablará de cómo podemos ofrecer las mejores terapias para estos pacientes. La tercera de las presentaciones versará sobre qué papel le queda, si queda alguno y cómo hacerlo, de inmunoterapia en segunda línea. Pacientes que ya han progresado a una primera línea. Para eso tenemos al profesor Roy Herbst de la Universidad de Yale para revisar esta temática. Y por último, la profesora Marina Garasino nos hablará de la secuenciación óptima del tratamiento y del mantenimiento. Es decir, cómo todo este aluvión de ensayos clínicos positivos podemos ordenar este puzzle y ordenar los tratamientos para que al final los pacientes, que es a lo que nos debemos, obtengan el máximo beneficio de estas terapias tan costosas, pero que tantas alegrías nos están proporcionando a pacientes y familiares y los médicos que nos dedicamos a cuidar de los pacientes de cáncer de pulmón. El profesor Rosell ya está en la pantalla. Buenas tardes, Rafael.
Buenas tardes, Antonio. Buenas tardes también a todos. Para mí es Carlos Camps Herrero en particular. No me quisiera extender tampoco demasiado. Mi papel es de asistencia al doctor Antonio Calles en llevar a buen término la moderación de este elenco de investigadores internacionales clínicos, como ha comentado tanto el doctor Carlos Camps como ahora nuestro querido Antonio Calles. Entonces, Antonio, te dejo quizá a ti pues, dirigir principalmente la sesión, y estaré atento a complementar en cualquier momento que se necesite, y por supuesto también a ayudarte cuando haya espacio o tiempo para preguntas y respuestas. Gracias.
Muchas gracias, Rafael. Pues estamos en hora. Yo creo que es el momento de presentar al doctor Jordi Remón, compañero y excelente profesional responsable del área de tumores torácicos del Hospital HM Delfos en Barcelona. Le conoceréis todos, es un excelente y pionero investigador de cáncer de pulmón. Se formó en Barcelona, en el Hospital del Mar, estuvo formándose y profesionalizándose en el Hospital Gustave Roussy en París, donde ha dirigido numerosas publicaciones de prestigio, especial importancia a las terapias dirigidas, la inmunoterapia y el papel de la biopsia líquida. Para ello, Jordi nos va a hablar de las combinaciones de immune checkpoint inhibitors en primera línea. Hola, ¿qué tal? Buenas tardes, Jordi.
Empiezo, si os parece. Good afternoon, everyone. Thank you very much to the Scientific Committee for this kind invitation. For me, it's a real honor to stay this afternoon here, so thank you a lot. And during the next coming minutes, I will try to summarize the current evidence of the efficacy of immuno-oncology combination strategies in patients with advanced non-small cell lung cancer, and also how we can apply this knowledge in our daily clinical practice. I think that there is no doubt that the introduction of immunotherapy landscape has really changed in the last 5 years. Lo siento, pero no funcionan las diapositivas. Sorry. The immunotherapy landscape has really changed in the last 5 years with several immuno-oncology strategies that have been approved in the last 5 years in the first-line setting. I think the introduction of these immune checkpoint inhibitors, along with the introduction of targeted therapies, has really changed the prognosis of this population, and the outcome of these patients has really improved if we compare this outcome with historical data. Today, we could say also that there is a proportion of patients, of those patients whose tumors has a PD-L1 expression more than 50% might obtain benefit of the immunotherapies alone, just immunotherapy in monotherapy. However, even in this population with high PD-L1 expression, the immuno-oncology combination strategies the immuno-oncology strategies has been the standard of care for wild-type advanced non-small cell lung cancer population, regardless of the PD-L1 expression. Today, at least more than 20 clinical trials assessing the combination of immunotherapy either with chemotherapy or immunotherapy with or without chemotherapy compared with chemotherapy alone have really demonstrated that these immunocombination strategies improve the outcome compared with this chemotherapy, with a response rate ranging from 45 to 60% and reducing the risk of progressive disease approximately 40% and the risk of death 30%. And some of these strategies have already been approved for the health authorities. However, I think that we could clearly be aware that probably we do not need more Me-Too trials, and according to all the clinical data and all the pathological data collected in this trial, it will be really important to try to address what is the best strategy for each of our patients. Despite that sometimes it has been reported that the activity of these immunocombination strategies occur regardless of the PD-L1 expression, I think it's important to know if there is benefit according to the PD-L1 strategy, because it may help us to take some clinical decisions. For example, in non-squamous histology, the Keynote 189 trial reported that the combination of pembrolizumab, carboplatin, and pemetrexed significantly improved the overall survival compared with chemotherapy alone, and the magnitude of benefit was independently of the PD-L1 expression, even in the PD-L1 negative tumor. However, in the Empower 150, the exploratory analysis of the activity of the atezolizumab, bevacizumab, carboplatin, paclitaxel compared with carboplatin, paclitaxel, bevacizumab was only reported for those tumors with an intermediate PD-L1 expression. However, the survival benefit with this quadruplet it was not statistically significant for PD-L1 negative tumors or for tumors with a high PD-L1 expression. Always the combination of IO and chemotherapy is with 4 cycles of chemotherapy. However, today or in the coming month, we have learned that just 2 cycles of chemotherapy may be enough for obtaining a survival benefit. And this data come from the CheckMate 9LA trial, a randomized phase 3 clinical trial where the combination of nivolumab, ipilimumab, and chemotherapy compared with chemotherapy alone, again, significantly improved the overall survival and the progression-free survival compared with the chemotherapy, and again, the magnitude of benefit occurred regardless of the PD-L1 expression. In PD-L1 negative tumor, PD-L1 more than 1%, and also PD-L1 more than 50%. However, I think it's also important of this trial that this trial also reported the survival benefit for those tumors with an intermediate PD-L1 expression, PD-L1 from 1 to 49%, suggesting that it's a feasible strategy in the first-line setting. It's true that all of these combinations have reported a higher incidence of grade 3, grade 4 toxicity compared with chemotherapy, and also higher percentage of discontinuation. However, this higher risk of discontinuation do not have a negative impact in the long-term benefit for these strategies. Despite that there exist a lot of strategies, I think that not all of these immunocombination strategies will become a standard in our daily clinical practice. And I think that one of the more recent examples is the Poseidon Trial, a randomized phase 3 clinical trial assessing the combination of durvalumab with or without tremelimumab and 4 cycles of chemotherapy compared with chemotherapy alone. This trial only achieved one of the 2 co-primary endpoints, and durvalumab plus chemotherapy improved the progression-free survival compared with chemotherapy alone. However, this combination did not improve the overall survival. Based that only one of these 2 co-primary endpoints is positive, for me it's not a clear positive trial. And also if we take into account just the median overall survival or the 2 years overall survival with the combination of durvalumab and chemotherapy, we can see later that this percentage is lower than those reported in other combination strategies. As I mentioned at the beginning of my talk, the immunotherapy has really changed the prognosis of advanced non-small cell lung cancer patients, and according to the cpnm, the 2 years overall survival before the immunotherapy was just 20%. However, today, with the introduction of these immunocombination strategies, the 2 years overall survival for this population has been doubled, and today it's 40% independently of what combination strategy we use in our daily clinical practice. Sometimes the benefit of these immunocombination strategies has been perhaps criticized because perhaps this overall survival with these combinations could be overestimated because the control arm was underreported, or the results were not as we expected. However, as you can see here in this table, it's not all the combination strategies, just a summary for some of these trials. Not all of these trials in the control arm, the crossover to the immunotherapy was allowed. For me, this is not ethic, but more or less between 30 to 60% of these patients in the control arm receive an immunotherapy at the time of progressive disease. And if we take into account the median overall survival, if we don't take into account the median overall survival and we take into account the long-term benefit of this control arm, according to the 2, 3, or 4 years overall survival, you can see here that this median of this long benefit survival really mirrors the overall survival reported in the randomized phase 3 clinical trials that assessed the role of immunotherapy in second line, suggesting that probably the control arm did not overperform compared with historical data in these trials in first line setting. Again, there is the doubt if those patients with a PD-L1 less than 50% could be treated just with immunotherapy and sparing the chemotherapy. And I think that the answer comes from this pooled analysis by the FDA, which compared the immunotherapy versus immunotherapy and chemotherapy in tumors with a PD-L1 expression between 1 to 49%. And this pooled analysis strongly suggested that the combination of strategies reported a better progression-free survival, reducing the risk of progressive disease 40%, and improve the survival, reducing 30% the risk of death compared with immunotherapy alone. I think that also it's important that perhaps we cannot spare the chemotherapy in those not selected population, because even in a highly selected population treated with just immunotherapy exists the risk of rapid progression under immunotherapy. And in non-selected population, I think that it's important the example of the CheckMate 227 trial. This trial assessed the overall survival benefit with nivolumab and ipilimumab nivolumab in PD-L1 positive tumors compared with chemotherapy. This trial achieved the primary endpoint and also reported a very significant 2 years overall survival of 40%. The major concern is that at the beginning of the curves, at the beginning of the treatment, the curves crosses, meaning that there is a percentage of patients who do not obtain benefit of this strategy and might die at the beginning of the treatment. However, this might be clearly overcome with just the addition of 2 cycles of chemotherapy as reported in the Checkmate 9LA, that in this case, the curves did not cross and also obtain a long-term benefit of 2 years overall survival of approximately 40%, suggesting that perhaps the immunotherapy alone is not enough for avoid this hyperprogressive disease. As I mentioned today, the 2 years overall survival with a different combination of strategies is approximately 40%, and this benefit occurs regardless of the histological subtype and also independently of what combination we use in our daily clinical practice. However, when we split this long-term benefit according to the PD-L1 expression, you can see that there is some concerns, especially in some of these clinical trials. The long-term follow-up has reported that overall survival it's not significant, specifically in the PD-L1 negative tumors. I will just focalize in the Keynote 407, a randomized phase 3 clinical trial testing the combination of pembrolizumab and chemotherapy versus chemotherapy in patients with advanced squamous histological subtype. This trial or this combination is approved regardless of the PD-L1 expression, but as you can see here, in PD-L1 negative tumors, the 2 years overall survival is not statistically significant, suggesting that perhaps other strategies should be explored in a squamous histology and PD-L1 negative tumors. I think that it's relevant, again, the Checkmate 9LA trial, the subset analysis according to the histological subtype. In those tumors with a PD-L1 negative, the magnitude of benefit of the combination of nivolumab, ipilimumab, and chemotherapy was stronger for a squamous histology, has a ratio of 0.48, compared with a non-squamous histology with a hazard ratio of 0.75. However, in PD-L1 positive tumor, the benefit of these combinations had the same magnitude regardless of the histological subtype. And this data might suggest that perhaps in PD-L1 negative tumors and squamous histology, this combination of nivo, ipi, and chemotherapy could be suitable. But remember, this is just an exploratory analysis. Today, there is a strong data that immunocombination strategies work. However, not all of these trials answer the question what to do in our daily clinical practice. When we are in our consultation, we should take into account the data reported in clinical trials, but also the data coming from the patients, the type of the disease, comorbidities, etc. One of the major concerns is the age of the patients, and you know that the life expectancy is increasing over the time. And today, more than 70% of patients with a lung cancer are diagnosed over 65. It has been reported that sometimes the immunosenescence might explain why immunotherapy doesn't work in patients on elderly population. As you can see here in all of these tables, the efficacy of these immunocombination strategies decrease with the age, and especially it's really relevant in patients elderly than 75. However, there is a very limited number of patients elderly than 75. Despite that this immunosenescence exists, and there is an immunophenotype suggesting that exists this immunophenotype that really correlates with a lower efficacy of the immunotherapy, these immunosenescence do not correlate with the age of the patients, meaning that perhaps this lack of efficacy in elderly population, it's not for immunosenescence, could be related to other factors. And one of these factors could be the comorbidities. We know that as we are elderly, we have a higher risk of comorbidities, and 65% of patients elderly than 65 have more than 2 comorbidities, and these comorbidities might imply a polypharmacy. And in this analysis that it's very small with only 100 patients with advanced non-small cell lung cancer, it was clearly reported that those patients that had a polypharmacy, more than 5 drugs, had a lower progression-free survival or shorter progression-free survival compared with those patients without a polypharmacy. And this might suggest that these comorbidities imply a polypharmacy that might change the microbiome, negatively impacting in the efficacy of this immunotherapy. Also, I think it's important the efficacy of this combination in the 30% of lung cancer patients with prime metastasis advanced line. All of these trials allow to enroll patients with treated and asymptomatic brain metastases. And we know that in those patients previously treated, the benefit of the immunocombination strategies mirror the data reported in patients without brain metastases. It's important that the efficacy of chemotherapy is lower for those patients with baseline brain metastases compared with those patients without brain metastases. But as a clinician, I think that it will be very important to know what is the activity of this combination in those patients without pretreated brain metastases. And as you can see here in all of these trials, the 2 years overall survival of patients treated with immunocombination strategies and brain metastases is 35%. I think it's very important, this trial, this is a phase 2 clinical trial, the TESOBRAIN trial from the Spanish lung cancer group, which assessed in 40 patients with brain metastases and untreated brain metastases and asymptomatic, the efficacy of carboplatin, pemetrexed, and atezolizumab, followed by maintenance treatment. I think it is important the results of this trial reporting that the intracranial response rate and the extracranial response rate was really similar, approximately 40%. The intracranial progression-free survival was 7 months and the median progression-free survival up to 9 months. But the most relevant is that even in these patients that are untreated with brain metastases, they report the same 2 years overall survival. 30% of these patients are alive at 2 years, suggesting that in a specific subgroup of patients with brain metastases, it's not necessary the radiotherapy up front, and we can delay these strategies in case that progress under treatment with immunotherapy. Again, the patients with oncogenic alterations, we know that, for example, the KRAS do not hamper the activity of this combination, the immunostrategy combination, but also I think it's important to establish the role of these immunocombination strategies, for example, in EGFR mutant population, and whether we should use or not a quadruplet or a triplet in this strategy. In this retrospective analysis, with just 26 patients with EGFR mutant population treated with carboplatin, pemetrexed, and pembrolizumab, they reported a response rate of 42%, median progression-free survival of 8 months, and overall survival up to 3 years. And probably this data really mirrors the data reported with a quadruplet recently published with carboplatin, pemetrexed, bevacizumab, and atezolizumab, suggesting that perhaps not always it's necessary a quadruplet in case that we want to use a chemo-IO strategy in EGFR mutant population. It's true that we like to have a better selection of the patients that should be treated with immunocombination strategies, but the tumor mutational burden, it's not a good tool for selecting these patients. I think that will be important in the coming future to try to use the ctDNA, because similar to the oncogenic addicted tumor, the clearance of this ctDNA under treatment with immunotherapy or chemoimmunotherapy correlates with the efficacy of the treatment. And also it has been reported in the Empower 150 trial, where the ctDNA correlates with the tumor burden, and the clearance of this ctDNA correlates with the response rate and might help to decide what patients with a stable disease are obtaining or not benefit of this strategy. Today, also, I think it's important that treatment duration, as you can see here in these 2 clinical trials, those patients who complete the treatment has a very good outcome with a 3 years overall survival of more than 90%. But as you can see here, those patients who obtain this long-term benefit and complete the treatment are patients that at the beginning of the treatment achieve a complete response and a partial response. So this long-term benefit is as consequence because they complete 2 years of treatment or because they have a complete response or a partial response at the beginning of the treatment. I think that some explanation about this question came from the Checkmate 227 trial, because in this trial, those patients with a complete response or partial response after 6 months after treatment initiation, 70% of these patients were alive at 3 years independently of the PD-L1 expression. And I think that today, the complete response or partial response under treatment with immunotherapy, it's a prognostic marker for long-term survival benefit. And also the $1 million, what to do at the time of progressive disease after immunocombination strategies, and there are a lot of clinical trials that are trying to answer this question. Today, as a conclusion, I think that we could say that immunocombination strategy work in advanced lung cancer patients in first-line setting with a 2 years overall survival of 40%, independently of the histological subtype, independently of the PD-L1 expression, and also independently of the occurrence or not of brain metastases. Probably we do not need more Me Too trials. We need to select better the patients and to try to define what is is the best strategy for each patient. I think that will be important to try to introduce the ctDNA at the early stages of the disease to be sure that the treatment is working, and also probably in the future the combination of the ctDNA and the RECIST criteria will help us to define the best treatment duration for each patient, and probably Dr. Garesino will answer the 1 million question about what to do at the time of progression. And thank you very much for your kind attention.
Muchas gracias, Jordi, por tu extensa y profunda revisión de las combinaciones de inhibidores del punto de control inmunológico. Como veis, ha habido algunos problemas técnicos al principio. Yo creo que esto es motivo para que os enganchéis al formato presencial. Ya es posible con las medidas de seguridad y poco a poco tenemos que volver a la normalidad y a volvernos a ver presencialmente. De todas maneras, hemos podido ver sin ningún problema toda la presentación de Jordi. No sé si nos estás escuchando, pero luego dejaremos tiempo para el debate. La segunda presentación corre a cargo del profesor Jürgen Wolf, del Centro de Oncología Integrada en Colonia. Jürgen Wolf es un investigador principal, pionero en muchas terapias dirigidas, investigador principal de muchos ensayos clínicos y líder de muchos proyectos de investigación que transforman el paradigma del tratamiento de los pacientes con cáncer de pulmón, y que hoy vamos a tener la suerte de poder escucharle sobre las opciones para obtener el mayor beneficio en el subgrupo de pacientes con alta expresión de PDL1, lo que llamamos PDL1 de más del 50%. Good afternoon, Professor Wolf. I don't know if you are listening. Can you?
Yeah, good afternoon. Can you hear me?
Hi, welcome.
Hi.
Welcome to this second EcoLung Summit, and thank you for being there. We are all excited to listen to your presentation. So, when you are ready.
Yeah, thank you. Hello to everybody, and thank you for the kind introduction, and above all, thank you for the invitation to this exciting meeting. So, my talk is the best treatment option for patients with a PDL1 expression of more than 50%. These are my disclosures. And I think the first question regarding this topic is which patients do we talk about? So we are all aware that targeted therapy is now standard therapy in the first line situation for 5 driver mutation, and this overlaps largely with the situation in the large randomized trials evaluating IO in the first line. All these trials excluded EGF receptor mutated and ALK fusion positive patients. So mean these randomized trial data have a potential relevance for around 85% of patients with advanced non-small cell lung cancer. However, as we all know, there's a really an impressive dynamics in the field of targeted therapy, and more driver mutations now are characterized, and more driver mutations are also targetable, and we have more and more information about efficacy in the first line situation. And so I think this means that we should consider in the interpretation of the data as well as in future study planning that even in these EGF receptor and ALK negative patient populations, there is a pronounced heterogeneity. So PDL1 prevalence in these patients, in these driver mutation negative patients. So it has been summarized in a recent paper in Modern Pathology, real world data as well as a large randomized trial. The frequency is about 1/3 of these patients. And we all know these data. This was the first landmark trial introducing immune checkpoint inhibitor monotherapy in this setting, the Keynote 025 trials. And with really convincing and very clear results for PFS as well as for overall survival. And Martin Reck has published 2-year survival update with a 25 months median follow-up, and we see that such a really convincing results are maintained despite a relatively high rate of crossover. But what we have also seen is that no significant benefit was seen in this updated analysis in the squamous histology subgroup and in female patients. Since The reasons for this are unclear, but we have to be aware of it in the future. So then we have seen the introduction of two more monotherapies in the first-line setting in PD-L1 high expressing patients. This was a cemiplimab, and I apologize. This slide has gone lost in my talk. But then the second trial, very recent trial, was the IMpower 110 trial, which approved the atezolizumab in the first-line setting. And as what you can see here are the survival results. Also, all these patients are high PD-L1 expressors according to the tumor cell score, and the hazard ratios are very comparable to that what we have seen, for instance, with a pembrolizumab. Also the median overall survival, it's at 13 months versus 22 months, and it's a hazard ratio of 0.59. So what about the combinations in this patient group? KEYNOTE-189 was here, the landmark trial, and if we look only in the PD-L1 50% and more subgroup, also very convincing results for the overall survival with a hazard ratio of 0.42, and the median overall survival was not reached in the original publication, even not in the follow-up published in JCO 220. But what we saw here is a difference in the 2-year survival rate of 52% with a combination therapy versus around 40% with a chemotherapy. And this is a very recent update of KEYNOTE-189 published this year. Here again, marked in red, the PD-L1 high expressors overall survival still significant. So hazard ratio now 0.71, 3-year overall survival rate. It's a smaller difference now. So also I think the reason is not clear. So I think the contribution of the so-called plateau is still an open question. So I think observation period is still too short, and also the influence of the crossover still has to be elucidated of these results. So there are a lot of other, we have seen also in the previous talks, there are also a lot of other IO chemo combo phase trials leading to approval of such regimens in the first line setting. Do not want to go due to reasons of time in detail into all these trials, but all these trials showed a significant benefit in progression-free survival. And some of these trials, but not all, also for overall survival. And let us have a look now into the PD-L1 high subgroup in this trial. So here is a comparison of the results in the KEYNOTE-189, IMpower 150 and IMpower 130. And you see here in the PD-L1 high expressors hazard ratio, very convincing, very clear, 0.42 in the KEYNOTE-189, but not significant in the IMpower 150 and IMpower 130. So the results, if you compare, also it's always difficult to make cross-trial comparisons. I think in the KEYNOTE-189, these are very unambiguous results. Also, the tumor performance score is a well-established biomarker and the method is well-established for the PD-L1 assessment in the IMpower trials. There is not such a well-established biomarker, at least if I look on the results of the German ring trials. Also, there was a very high inter-laboratory concordance for assessment of PD-L1 on the tumor cells, but not very convincing results concerning concordance between different laboratories if PD-L1 was assessed on the immune cells. So the crossover is comparable between these trials. It was in all trials in the range of around 30%. So what about IO chemo combo in this setting in squamous cell carcinoma? So here are the results of the KEYNOTE-407 trial. This was a positive trial concerning overall survival at PFS. But if you look into PD-L1 high subgroup, there were also significant results concerning PFS, but there was no significant overall survival benefit. The reason is unclear. Maybe it's a question of lower patient numbers. But compared with the KEYNOTE-024, the squamous cell subgroup, which had a frequency of around 20% in this trial, there was a significant overall survival benefit. Then now we also have the checkmate 9A1, another principle, so immune checkpoint combination with initial chemotherapy. And here you see the results again in the PD-L1 high expressors. Overall survival and PFS are significantly better, and these results are independent from histology in this subgroup. So also we have learned not to do cross-trial comparisons because there is no direct comparison of these different therapy regimens. I think it makes sense to compare these results, and let us start with efficacy. And you see in particular for the median overall survival, so the range of, or the magnitude of a benefit, it's very comparable in all these trials. So it's always a hazard ratio between 0.6 and 0.7. And this holds true here in this table only for the subgroup with a high PD-L1 expression. In principle, it's the same holds true also for the median PFS. And if you look here on the 2-year overall survival rates, which were reported for the checkmate 24 and the KEYNOTE-189, so the results are nearly identical. So nearly identical efficacy of all these regimens in this subgroup. And if we add now toxicity, but I have to mention this is a toxicity for all PD-L1 subgroups in this trial. So I could not find, also not in the supplements, toxicity only for the PD-L1 high expressors, but I think it's okay to take here the toxicity of all subgroups. And here are striking differences. So look at the checkmate 024 and the IMpower 110. So the grade 3 and 4 toxicity proportion is around 30%. And it's around 70% in the KEYNOTE-189 and KEYNOTE-407. So it's in between in the checkmate 9LA with around 50%. But this is also a very uniform picture. It's a substantial higher toxicity in these combination trials and this combination with chemotherapy trials. This holds true even for the fatal adverse events, as you can see here. 7% in the KEYNOTE-189, 8.2% KEYNOTE-407, only 0.6 in the checkmate 24. And also the frequency of permanent discontinuation here is significantly higher. It's only 7% in the immunotherapy arm in the checkmate 024 trial, and it's around 30%, 20 to 30% in the combination trial. So I think if you see this table, then it's hard to find any arguments for IO chemo combo in these patients. But of course, there are such arguments. And one is a hyperprogressive disease. We have already heard about this in the first talk. Here is an image of the publication in JAMA Oncology in 2018. But I'm not so sure, but maybe we can discuss later in the discussion section whether this can be transferred to this situation we are discussing now here. What we saw in this paper was a frequency of 13.8% of hyperprogressive disease in PD-1, PD-L1 inhibitor-treated patients versus 5.1% in chemo-treated patients. But this was a retrospective study. It was not the first-line situation. These were relapsed patients. And most of these patients had a very high tumor load and a lot of metastatic sites, means these were patients with worse prognosis anyway. And then the second argument, also already mentioned in the first talk, was the argument of the crossing curves observed in some, not all, randomized trials with IO mono. It's shown here for the Checkmate 42 trial, pembro versus pembro chemo combo. Here the curves for the high PD-L1 expressors. The interpretation is not so easy in my view. It's not consistently observed in all trials, and nevertheless, despite this effect, there is an overall survival benefit in these trials, and with the lower toxicity. So with this, I come to my conclusions. If you have patients with advanced non-small cell lung cancer in the first-line situation with a high PD-L1 expression, then I think the first measure is to do also the NGS testing, and then to look whether you can select patients for targeted therapy with first-line evidence. And this is more than the EGF receptor and the ALK, which are excluded only in all these large trials, phase 3 trials we are discussing now. But then if you have no targeted driver, then there are these option IO mono or different regimens for IO chemotherapy combo, including the IO chemotherapy combo. So, but my opinion is that clearly IO monotherapy should be the preferred option. As I have shown you, this therapy has the same efficacy as a combo therapy with regard to PFS and overall survival, and it really has a substantially lower toxicity. And as we already have heard in the first talk, a lot of these patients are older patients, and toxicity is really an argument for the quality of life of these patients and the safety of the therapy. And it's really a remarkable difference. But nevertheless, I think there are patients where we should consider IO chemotherapy combos. So these are fit patients with rapid progressive disease. I think if you really have the situation that there is a high therapy pressures, then you can consider it, and in particular you should consider it. And this is also our clinical routine here in Cologne. If we have a patient with a high therapy pressure and still missing NGS results, and we cannot wait for the NGS results, then clearly the first choice is IO chemotherapy, combo therapy. Okay, with this I come to my end. Thank you for your attention, and I'm looking forward to the discussion.
Thank you very much, Professor Wolf, for your very nice presentation. Ahora nos iremos al papel de la inmunoterapia en segunda línea. Hemos estado revisando las dos presentaciones, todo el espectro de posibilidades que tenemos en primera línea, pero ¿qué ocurre con los pacientes que tienen que empezar una segunda línea y sucesivas? Para ello, el profesor Herbst nos va a dar una excelente revisión sobre lo que es conocido y hacia dónde nos movemos. El profesor Herbst es por todos conocido por sus grandes aportaciones al campo de la medicina de precisión y las terapias dirigidas en cáncer de pulmón y las aportaciones que ha tenido en inmunoterapia en cáncer de pulmón. Esto es un topic de interés creciente ahora con el reciente aprobación por parte de la FDA de atezolizumab en el setting adyuvante, del durvalumab en el setting de la enfermedad localmente avanzada, es decir, que vamos a ver pacientes que después de un tratamiento potencialmente curativo también recaen, además de los pacientes que debutan directamente con enfermedad metastásica. Es un tema de gran interés y del que tenemos una necesidad clínica urgente. Professor Herbst, I don't know if you can hear us. It's a great pleasure to have you on board in this second EcoLung Summit. I was talking to the audience of your huge expertise in the field of immunotherapy and target therapy, and how your investigations have transformed the way we treat patients with lung cancer, and it will be an honor to listen to your presentation today about the role of immunotherapy in the second-line setting. So when you are ready, please.
Thank you. Do you hear me?
Yes, we can hear you.
Well, it's a pleasure to be here today, and thank you for having me. Now, I'm going to go a little bit fast because really we've moved immunotherapy to the frontline setting, but I will show you some data from the second line setting as well, which are, of course, quite impressive. I don't need to really tell this group how much progress we've made in the treatment of lung cancer over the last 20 years. And a lot of that has really been because of the paradigm shift of immunotherapy. And this is data, these are data from the United States, but you can clearly see that around the world, the death rates for lung cancer are declining even more than the incidence, and in large part, this is because of immunotherapy and targeted therapies. So what I want to talk about is just immunotherapy in the second line setting. And this is one of the very first patients. This is from Scott Gettinger. And this is now, it's incredible, it's almost 11, 12 years now since the MDX-1106 nivolumab trial, where in that phase 1 trial, patients with 3-time or 4-time refractory disease. This is a squamous patient, still alive actually, doing quite well, with multiple areas of disease shown here on the left, with very quick response and then durable response. And these are the data from that trial, the Checkmate 3 trial. And you can see the actuarial 5-year survival is 16%. And you know, the key about all this, of course, is the tail of the curve. The fact that we really, we need to figure out a little bit more. There were no biomarkers in this trial. Everyone was accepted, but you can clearly see that there's a tail of the curve of 16% of patients refractory disease. Now, biomarkers are important, and I would contest that PD-L1 is the best biomarker still, although there are all these problems with heterogeneity. Here you can see one piece of tissue, one area that's quite negative for PD-L1, one that's positive. Of course, you get different levels of staining depending on the antibody, although I think we now know that most of the antibodies, perhaps except SP142, are pretty similar. We also know that where you measure it can matter. The green is cytokeratin, so tumor cells, stroma here with the DAPI with the blue, and the red is PD-L1. So where you measure, how you measure it, is a variable that I think makes this marker somewhat less than perfect. Also, the precision and the ability to pick it up, the sensitivity, is a problem as well. We call many patients negative who probably are somewhat positive. Well, this is a trial. The one thing that I'll show you, the main part of my 15 minutes, the most updated data for pembrolizumab, the Keynote-10, it's actually in the JTO that just came out yesterday. So this study was started, 7 years ago. Advanced lung cancer, confirmed PD after 1 line of therapy. So it was 1 or more lines of therapy, no active brain metastases, performance 0 to 1, PD-L1 had to be 1%. So this was the first real use of PD-L1 as an eligibility criteria. So remember, when I show you these data, there was no one who was 0, and this was using the 22C3, no active autoimmune disease, and no ILD or pneumonitis. And if you recall, this trial had a large number of patients, 1,034, with 3 arms. Docetaxel, because it was second or more line, standard of care, versus pembrolizumab at 2 dose levels, 2 or 10 milligram per kilogram. Of course, it's not dosed that way anymore, although it was given every 3 weeks with pembro until 2 years, or 17 cycles of 3 weeks, or a crossover. And very important that crossover was allowed, and that affects the control arm, as I'll show you. It was a dual primary of overall survival and PFS, which of course you know it met, an overall response rate and disease duration of response. Well, here's the eligibility criteria, and what I want to show you here is I'm going to focus on those patients who went for 2 years and those that had a second course of pembrolizumab. But you can see if you just look at pembrolizumab versus chemotherapy, it's basically a 2-to-1 randomization with the 2 doses. There were no major differences between the 2 groups. And then if you look at those 35 cycle patients versus those that had a second course, there are no gross differences. Of course, with a small number, you do see some differences. But here's the punchline. If you look on the left, the PD-L1 now also with actuarial 5-year survival, you can see very much like was seen for the nivolumab at 5 years, 15.6%, nearly identical as the nivolumab data, 6.5% for the control group. Remember, this would have been 0 in the old days, but the crossover did occur, and you can see the tail of the curve again. being quite precise. And then, probably the, preceding keynote 24 just by a little bit, but you can see 25% 1 year when you take only the PD-L1 50% prospectively versus 8.2% for the higher PD-L1 in the control. So PD-L1 matters, tail on the curve. What I want to show you that's a little new today, here's the progression-free survival, and for greater than 1%, pembrolizumab versus control, hazard ratio 0.84. For the greater than 50%, which is really where most of the benefit is seen, hazard ratio 0.57. Now, overall response rate shown here, the pembrolizumab docetaxel, this is at the 50%, here is at the 1%. You can see the response rates, of course, are higher. Objective response rate, docetaxel 9.6, about the same in both groups, 21% at the PD-L1 1% cutoff, 33% in the refractory setting at the higher cutoff. But then what about those patients who went for 35 cycles? There were 79 patients who completed all 35 cycles, 2 years on the protocol. The 3-year overall survival rate from completion of 35 cycles was 83%. And at data cutoff, 61 of the 79 patients were alive, 38 of whom were alive without PD. And you can see of those 79, nearly all of them had a response, and actually 20% almost had complete response, about 80% had partial response, and there was one patient who had long-term stable disease. And if you look at treatment duration and time to response for the second course of pembrolizumab, there were 21 patients who progressed, meaning they went for the 2 years and then they progressed, and we actually retreated 21 of those patients worldwide, and half of them responded a second time to pembrolizumab. So this is the point I want to make is that we can, in cases like this, use the drug potentially in a second-line setting. Complete response, one complete response, 10 or 47.6 partial responses, 28.6 stable disease. Nearly everyone had some benefit. 3 patients did not. And I didn't mention it, but the toxicity was really no different than what was seen previously and is expected with immunotherapy. So with a 5-year median follow-up, pembrolizumab monotherapy continued to provide clinically meaningful improvements in overall survival and PFS with docetaxel as second-line or greater treatment in patients. 5-year overall survival rates were more than doubled compared to docetaxel. 15.6% of patients with PD-L1 TPS greater than 1% in the pembrolizumab group were alive at 5 years. Patients who completed 35 or 2 years of pembro experienced durable responses. I showed you almost everyone responded. Second course pembro provided meaningful disease control. And I didn't show you, but incidence of any grade or grade 3 to 5 treatment-related AE was lower with pembro versus docetaxel, and no new safety signals. So just in the last minutes, a couple of quick points. I know that things are running a little over, and I want to be here for the discussion. You can see that pembrolizumab works in brain mets. This is an investigator-initiated trial that Sarah Goldberg ran with Dr. Chang, a neurosurgeon, and Dr. Kluger, who treats mostly melanoma here. We actually showed many years ago, and now it's become standard, that if you have small brain mets and you treat with pembrolizumab, you can see response. And actually the extracerebral response in green, the brain response in yellow, they tend to sort of align. Can precision medicine help? Absolutely. I think we're learning now, this is a atezolizumab data, that patients who have wonderful responses see increases in their CD8 positive T cells, the adaptive immune response, and they see upregulation of granzyme, perforin, TNF, and interferon. But we also know that tumors that don't respond either have an immune desert or immune excluded, meaning that pre and post biopsies, as was done in these studies, you don't see any increase in CD8 positive cells, or if you do see some small increase in CD8 positive cells, you don't see any upregulation of granzyme, perforin, and so forth. This is all in the paper shown here. Or you sometimes get T cells that never get to the tumor. So these are all mechanisms that can be thought of as we think about the next second line or more therapy after refractory disease to immunotherapy. So we need targeted second line therapy. We have a trial called the LungMap trial in the US among all of our cooperative groups. And I just show you this trial now because this is a trial where we're actually studying in patients in a non-matched way. So we don't have any biomarkers yet, but patients who fail immunotherapy, we're trying different combinations right now. We just finished a combination of pembrolizumab, ramucirumab. Those data are maturing, and we're about to start a trial of N803. That's an IL-15 agonist plus pembrolizumab versus standard of care. So we're trying combinations in this setting. We have to understand, and it's all over the United States, we have to understand why patients are resistant. I would contest that this is a good way to think of it. If you have patients who respond, this is work with Liping Chen and David Rim here at Yale, that about 17% of lung cancer cases, we looked at 450, have high PD-L1, that's the brown, and high TIL, that's the blue. These are probably the patients that respond to immune therapy. We saw that both with pembrolizumab and nivolumab. And those patients either have a durable response, those are the patients that go 2 or more years. They can acquire resistance, or they can have primary resistance, and they don't respond at all. So just here we have 3 things that we need to deal with. But then many of these patients, for example, here's a lot of TIL cells in blue, but PD-L1 is negative, there's no brown. So these patients, we call these type 3. These are tumors that probably are primed to respond to immunotherapy, but PD-L1 is probably not the checkpoint. And then, as I think most of you know, most lung cancer patients are either type 1 or type 4, meaning that they have no PD-L1 and no TIL, or they have TIL, they have no TIL and a little bit of PD-L1, probably driven by oncogene expression. But either way, these cells, type 1 and type 4, with no T cells, they're cold tumors, and they're going to need some help as well. So I'll make this my last slide for the sake of time. It's really going to be important in the future to think about biomarkers and how to target resistance in immune therapy. We're going to need to think, for example, here's work from Katie Paletti at Yale, that here's a tumor that responded to immunotherapy, tremelimumab, durvalumab, but then became resistant in the abdomen. Actually, this tumor, this is copy number data. This tumor actually lost both copies of beta-2 microglobulin. What does that mean? That without beta-2 microglobulin, which is an important component of MHC, you're not going to have an adaptive immune response. You've lost MHC class 2. So this is one mechanism of resistance. And now we also know from work from Dr. Schalper and our team that there are tumors that are cold, and here's a cold tumor. There's no CD3, that would be the red. And here are 2 examples of tumors that are hot. The red shows CD3 cells, but now we can get even more granular. We can look at granzyme and Ki67. These tumors have low granzyme and Ki67, that's the green and the white. And these tumors have high granzyme and Ki67, that's the green and the white. So this means that these have T cells that look like they're active, these don't. And interestingly, when you look at overall survival retrospectively, the tumors that do best are those tumors that actually the granzyme and Ki67 are low. Doesn't make a lot of sense until you do some molecular studies and PDX mice, which I'll just tell you about very briefly, that actually tell us that these are the tumor cells that are probably, and the microenvironments that are probably ready for priming. And there's actually a recent paper, and this will be my last slide, that shows that we know now that there are burned out CD8 T cells. So it's very likely that these tumors probably have those burned out cells, and these burned out, we call them effector burnout, EBO cells, they probably are the ones that are benefiting from PD-1 or PD-1 plus therapy. So with that, I'll stop at my 15 minutes, and I'm looking forward to the discussion in a few minutes. Thank you.
Muchísimas gracias, doctor Herbst, por esta fantástica presentación. Vamos ya a la 4ª y última ponencia de esta sesión general. Para ello, la doctora Marina Garasino nos hablará de toda esta información que hemos ido recogiendo, cómo recomponer ese puzzle y cómo poder hacer la mejor estrategia de tratamiento. La doctora Marina Garasino es internacionalmente conocida por múltiples publicaciones y por múltiples líneas de investigación. Ha sido durante muchos años la líder del grupo de tumores torácicos del Instituto Italiano de Tumores en Milán, y recientemente se ha movido a la Universidad de Chicago, donde es profesora de medicina. Además además de hacer su gran labor investigadora, pues es una de las personas clave en el movimiento de mujeres por la oncología, Women for Oncology. También ha desarrollado el registro internacional en tiempo real de los pacientes con COVID y cáncer de pulmón, el estudio TeraVolt, en la que muchos centros han participado y que dio importante información sobre la gravedad que tenía esta infección en los pacientes con cáncer de pulmón y que nos ha ayudado a tomar decisiones terapéuticas durante los momentos difíciles de la pandemia. Por tanto, es para mí un placer dar la presentación a Marina. Y Marina, welcome to the second ECOLAN Summit. I don't know if you can hear us.
I can hear you. Can you hear me?
Yes, I can hear you and I can see you perfectly, Marina. It's great to see you.
Great to see you. I'm very happy to be here today, and I will try to go very quickly so we can save some time for the discussion, because the majority of the things were already presented. And here you have my disclosures. And coming back to what was said before, so we know that there are multiple treatments for the advanced non-small cell lung cancer. In particular, here in the United States, there are single agents that are approved also for PD-L1 more than 1% and not just 50% as in Europe. And we know also that there are multiple combinations. So rendering how to make the decisions in 2021 very difficult. And although Roy made an excellent presentation about the biomarkers, I think that we are still far from defining the right set for each one of the combinations. For the combination, I believe that the only thing that we can see now working is the chemotherapy combined with the immune checkpoint inhibitors. There are some signals also for the TIGIT, but we know that we saw just the first results of the phase 2 trial. We know that it works better in PD-L1 more than 50%, and we hope to see the final results very soon. I don't want to spend some time, but just to remember that there are some trials that are widely used in the treatment of non-small cell lung cancer. This is the Keynote 189 that was presented before a lot, and importantly, at least in the non-squamous population, it seems that the benefit goes across all the three subgroups, and it is independent by the PD-L1 expression. Moving to the possibility to use something different than PD-L1, I think that the tumor mutational burden was widely used, but we know that there is some benefit for the selection of patients with single agents, but the selection of patients for chemotherapy is still far to come. The twin trial, the Keynote 407, this was a twin trial with the Keynote 189, but I think that one part is important. So although the hazard ratio are very similar for PD-L1 in the overall population, positive and negative, the benefit in PD-L1 less than 1% is less compared to PD-L1 positive. And this is something that we can discuss in the end, because this could be a good part of patients where maybe some different combinations can be important. This is the Empower 150, we know very well the trial. This is a quadruplet with the combination of carbopaclitaxel and atezo and bev. The results are very positive again, but again, there is the doubt that maybe the backbone of the chemotherapy can play a role, and the taxane, as we saw also in the 407, they are not the best companions to be added to the immunotherapy. There is a lot of preclinical work on that, so still the best chemotherapy to be added is still debatable. And if we remove the bevacizumab, we see that the benefit is not anymore so much. And I believe that, again, here there is still a role for the anti-angiogenics that is not very well understood. If we move to the Empower Lung 3, we have to remember that I think that is the most important part of the year. We don't have just the pembrolizumab and the nivo-ipi, but we have some new molecules. One is cemiplimab. This is the trial, was a randomized trial. It was done in smokers. The population was broader than in the other trial. As you can see, also the stage 3 and the stage 3C were included in this trial. And you can see that although the data are very early, you can see that more or less the benefit of cemiplimab combined to the chemotherapy is exactly the same that what we observed also in the other trial. There is also some other trials. One is camrelizumab. Again, the hazard ratio is very similar, and also the benefit in terms of PD-L1 positive or negative is very similar again. And also tislelizumab was an Asian trial, was developed in combination with chemotherapy and also over the chemotherapy alone. And as you can see, again, also here, the benefit is very similar. So it is possible that in the next future, the scenario of the treatment of non-small cell lung cancer in the first line will be not just one drug, but can be multiple drugs. And we have to understand how we can translate the Asian data to the Western population. Moving to the PD-L1 more than 50%, I don't want to spend some more time, but I think that this was a very important presentation in the virtual plenary earlier this year. They are data coming from the Flatiron, and you can see that as it was said before, the benefit in PD-L1 positive of the chemotherapy and the immunotherapy and the monotherapy alone was very similar, but consistently to what we observed in many subgroup analyses of these trials, there is a benefit of combining chemotherapy to immunotherapy in never smokers patients. So I think that this population, and we can discuss also about the women, is a population where I feel much more confident to use the combination than the immunotherapy. There are some data also in ASCO 2021 for the gray area between 1 and 49%. This was a meta-analysis done by FDA of the most important clinical trials. And you can see that although the numbers at the end were just small because 600 and 500 patients, the results were very clear. So in the population between 1 and 49%, I think that the single agent is not an option anymore. And this maybe can be easier for the European countries where PD-L1, where the single agent is not approved yet for PD-L1 more than 1%, but this was not so clear in the United States. Then we have the discussion whether to combine or not with the anti-CTLA-4. I think that, as said before, the 9LA, just 2 cycles of chemo with the maintenance of nivo-ipi, is a very interesting trial. This is a very pragmatic trial. I think that we want to spare the chemotherapy, but again, the chemotherapy is the only agent that is able to increase the overall survival in this population. As you can see, this was on the left ASCO 2020, on the right we have ASCO 2021. You can see that the hazard ratio more or less is the same, but again, there is a continuous drop of the curves, and it seems that there is a tail for nivo-ipi at 30%. But again, we don't know if the tail of the curves is just represented by the patient's PD-L1 more than 50%. This is the subgroup analysis, PD-L1 less than 1% and more than 1%. The hazard ratio is very similar, and there was a discussion in ASCO this year if we can use in the squamous PD-L1 less than 1% the combination with nivo-ipi after the chemotherapy. This was clearly the best hazard ratio that we saw, although we can see that there is a huge confidence interval. And I don't think that this is the correct way to analyze a subgroup analysis of a subgroup analysis, but if we go back to what I said before about the PD-L1 negative in the squamous population in the 407, I think that we should consider to use this combination in this setting. Final results were presented for the Poseidon trial, again suggesting that the role of the anti-CTLA-4 in the treatment of non-small cell lung cancer is debatable. We see that there is an increase of the overall survival, but was not statistically significant with durvalumab combined with the chemotherapy. And we can see that the benefit was statistically significant when we added also tremelimumab. But again, if you see the magnitude of the effect is not so high as we could expect by a combination as before. And just to go back to the old story of the 227, I don't want to go into the details of the 227, but if you remember, this is the primary endpoint, and you can see that the benefit of EP was about 5 or 10% of absolute risk in PD-L1 more than 1%. There was an increase in PD-L1 more than 50%, but you have to remember that there was a trial with pembro-EP that was totally negative in this population. And again, coming back to the results and to the discussion whether to use or not the EP in the squamous PD-L1 negative, you can see that in the Checkmate 227, the benefit of EP in the squamous, 34% of patients alive at 3 years in the non-squamous, and 35% of patients alive at 3 years in the squamous, suggesting that maybe the phenotype does not play a major role. For the maintenance, there is, I think that is important to remember this meta-analysis done by Eddie Garon, and you can see that the benefit of the maintenance was very similar to what was obtained in the Paramount, and the addition of the immunotherapy to this setting, it seems to be important, although, as I said before, it was paid in terms of toxicity. So to conclude, I think that it's difficult to find a biological-based strategy. I think that pembro is a very good option for patients with PD-L1 more than 50%, but we should consider the combination in particular in patients never smokers and maybe also with an aggressive tumors. We have a lot of open questions, such as how long we have to continue with immunotherapy. 2 years are enough. We don't know if there is a best chemo regimen to be added, and we still don't know where is the best place for the anti-CTLA-4 in the treatment strategy of non-small cell lung cancer. I think that we have incredibly great results, and I believe that in this uncertainty, we have to speak with the patients and to make some shared decisions about the toxicity, about the length of the chemotherapy, and about our uncertainty to find the best treatment for them. And thank you for your attention.
Thank you very much, Marina, for your nice presentation and also for saving some time for the discussion. Now it's time for question and discussion. I want to welcome to the discussion Professor Rafael Rosell and the 4 presenters of the great general session of today. I don't know if no sé si alguien en la sala tiene alguna pregunta o alguna cuestión que hacer. Si lo tiene, por favor, levante la mano y trasladamos las preguntas a los ponentes. Ahora yo os puedo ver a todos los ponentes. Bueno, yo tengo una pregunta para el doctor Remón. Voy a ir por orden. Si sale alguna cuestión, paramos la conversación y hacemos caso a esa pregunta. Has dejado claro, Jordi, que las combinaciones pues son útiles en todos los escenarios, ¿no? Para pacientes con PD-L1 alto, bajo, metástasis cerebrales y metástasis cerebrales, pacientes con mutaciones driver o no. ¿Tratarías a todos los pacientes con combinaciones de quimio-ayo o habría, si no, qué pacientes no darías combinaciones con quimioterapia y dejarías solo tratamiento con monoterapia?
Bueno, no sé si contestar en inglés o en castellano, pero bueno, en un principio la monoterapia lo haría en pacientes con PDL1 de más del 50%, que tuvieran un bajo volumen tumoral y no fueran muy sintomáticos, excepto que fueran mujeres y no fumadoras. En el caso de nivo-IPI no está aprobado en más del 1% por la EMA, y me parece que en pacientes que no están seleccionados por PDL1, como he comentado, la inmunoterapia sola, a pesar de que tiene un buen beneficio esta combinación sin quimioterapia a largo plazo, existe mucho riesgo de que pueda existir una hiperprogresión en un 25% de los pacientes y probablemente pueden fallecer. Entonces me parece un poco más arriesgado. Y la quimioterapia la evitaría tan solo 2 ciclos en aquellos pacientes que a lo mejor no son fit para recibir 4 ciclos.
Muchas gracias, Jordi, por tu contestación. ¿Alguna pregunta? Rafael, no sé si tienes alguna pregunta que hacer a alguno de los ponentes. Han surgido muchos asuntos que podemos discutir.
Of course. Thank you very much. Just to join to congratulate all the speakers. Therefore, I believe all are agreeing that it has been a very complete presentations on the cutting edge, and therefore there are multiple questions. I was very impressed for all the presentations, including, of course, Roy Herz and Marina. But I want to ask Dr. Jürgen Wolf, because you were in the presentation bypassing, mentioning what now has been commented, how we can predict patients that could have a negative impact of immunotherapy in terms of hyperprogression that you were trying to clarify a bit in one of your last slides. If you have some comments or you can add something on this, of course, Roy or Marina or Jordi or anyone else in the audience, my co-chair, Dr. Antonio Calles. But Dr. Wolf, you can give us some further consideration for what could be the phenomena of clinical hyperprogressive disease.
We can't hear Professor Wolf.
Excuse me, sorry. So it's also, as a hyperprogressive disease is also a matter of many controversial discussions in our center. So there are a lot of hypotheses already described in this paper, but I think we should not forget that it's also observed in chemotherapy only, and I think we also observe it in TKI therapy. So my feeling is that if you have an exponential growth of tumor cells, so more you are on the right side of the curve, so more dynamically you see the tumor growth, and so I think I'm not sure whether this is really specific to immunotherapy. And in addition, it was a retrospective analysis, relapsed patients, and the question is, can we really transfer these observations to the first line situation? Because I think it's really a difficult decision to treat a patient in the first line situation with an IO chemo combo. I have shown you the summary of efficacy and toxicity, and we have also seen it in the other talks. There is definitely no difference so far in efficacy. The best data are for the Checkmate 24, but it's really a substantial increase in toxicity. So I really have problems. So I have shown these two situations where I consider IO chemo combo. This is really a very high, high clinical pressure to start therapy. And all these patients showing in this retrospective analysis in the JAMA Oncology paper, hyperprogressive disease were patients with a high tumor load and a lot of metastasis, which I think perfectly fits to my hypothesis of the exponential growth.
May I comment? Because Roberto Ferrara was working with me at the time of the publication.
Yeah, I know. So I'm curious about your answer now.
Yeah, so I tell you why we started to work on this field. So we started to see this phenomenon mainly in patients who had EGFR mutations and ALK translocations. And we were able also to prove the phenomenon also in PDX harboring EGFR. And when the mice was treated with an anti-PD-1, clearly it was immunocompetent mice. And so we started to think that maybe the reason behind were not the T cells, because these mice didn't have the T cells, but they could be the macrophages. And then we made a second experiment because we thought that could be the FC portion of the antibody responsible of the polarization of the macrophages. And when we did the same experiments with the FAB2, so removing the FC portion, the hyperprogression disappeared. So I believe that this is not a phenomenon that can happen everywhere, but I think that we must be very careful with immunotherapy in patients with driver mutations, and that the FC portion can play a potential role. But this is clearly an observation in animal models. So, but it was basically the same. It was the same PDX that we had where we had the hyperprogression in the patient. So it was quite consistent.
Oh, interesting. But so very brief question to you. So for you, it's not an argument to start with IO chemo in the first line situation, the PDL-1 high resonance.
No, I think that we must be very careful with the never smokers. In fact, we saw the data that in the never smokers, the chemotherapy, immunotherapy works better. And I believe that one of the reasons is that the microenvironment of this population is different, and potentially there can be a switch of macrophages from M1 to M2 phenotype that can be responsible through the FC portion of the overactivation. There are many other theories about the Treg. There are other theories about the low density neutrophils. So this is not the only one. But I don't feel very well to treat the patients, never smokers, with the single agent.
Okay.
I think that is important, what Marina just pointed out. I think we have to make a call to action to do more comprehensive genomic profiling in metastatic lung cancer patients, especially in never smoker patients, because we can find driver mutations that can achieve better outcomes with target therapies, and also to avoid unnecessary immunotherapy with the risk of hyperprogression. So whether or not hyperprogression is a fact, or what the underlying mechanisms are behind that, I think we need to do molecular testing, broad molecular testing, just not only single panels for EGFR, ALK, and ROS, but also to detect all rare alterations that can have specific driver mutations. I don't know if the rest of the panel agrees or not with this observation.
Mm-hmm. Yeah, I agree.
So moving to precision medicine, seems like we are a little bit far from where we are actually currently in lung cancer with driver mutations. We know that if we divide, we conquer, as Julius Caesar said when passes the Rubicon River, but I don't think we are at that point for the immunotherapy treatments. Professor Herbst just pointed out that there could be 4 types of tumor infiltrations that can derive different responses to immunotherapy. I don't know if we are ready to incorporate this immune profiling in the clinical setting to select the best immunotherapy treatment for the patient, because at the end of the day, we need the right immunotherapy to the right patient at the right moment. I don't know if we are at this point right now. I don't know if you can go with this a little bit further.
Yeah, I would say absolutely it's time to do that. And, as I tried to show, I was going quickly for time, but we can understand what's going on in the tumor, both with PD-1, PD-L1, but also with the microenvironment. And there are multiple levels of regulation here. And it concerns me that in refractory patients, we're just putting combinations together, when really what we have to understand is, have we lost MHC? Have we lost beta-2 microglobulin? Then we need to use more innate immune mechanisms. Do we have T cells? Is a tumor cold? Then we have to look at some of the different interleukin approaches or ways to warm up the tumor. So I think we're moving in that direction. There's so much data now in patients who become refractory. We can pull those together. We're seeing some inklings of hope with like VEGF inhibitors, with other agents that target the microenvironment. So I think that could be very, very important in the future.
Thank you very much. I don't know if there is any question in the audience that you want to make to the presenters. I think we have a couple of minutes more. We are a little bit behind the schedule, but I think the panel of experts that we have today is worth it to ask some questions. Maybe we haven't talked this about, because it's worth it specifically for stage 4 lung cancer, but little by little we will have more patients treated with immunotherapy at early stages. This means unresectable stage 3 treated with consolidation durvalumab, or complete resect non-small cell lung cancer who progressed to atezolizumab, that recently got the FDA approval in the United States. And we will have this kind of patients in the clinic progressing either during immunotherapy treatment or after IO completion. Your treatment schemas or your treatment plans vary upon the type of progression these patients have. Do you consider re-challenging with immunotherapy in those patients? And if so, what kind of approach? Single agent, combinations?
I think that, for instance, the role of re-challenge is really limited indeed in patients with metastatic disease, and I think that there is some evidence that the re-challenge might work, especially for those patients with a long-lasting period since the last dose of immunotherapy. I think that the potential strategies of IO again will be again dependent on the PD-L1 expression, but also the time after the progression and the time since the last platinum dose of chemotherapy. And probably those patients who really progress under treatment with immunotherapy and consolidation strategy are completely refractory patients, and I think that it will be very difficult to re-challenge again with another IO strategy at this time. However, for those patients that probably has a relapse 1 year after the last dose of immunotherapy, could be suitable to re-challenge these patients at the time of progressive disease under immunotherapy, because in metastatic disease from the KEYNOTE-010 trial and also KEYNOTE-024 trial, those who are re-challenged and might obtain benefit are patients that at least complete the treatment 1 year before that the disease progressed. So it seems that other patients with a higher benefit of this re-challenge, but I think that today the data is really, really limited.
Thank you very much, Jordi. I think that we are currently on time. I want to invite Dr. Rosell to close this session. I want to thank all the presenters for the great presentations. I think we had a wonderful discussion, very nice presentation. We learned a lot. I think the important thing is that we will be able to bring new things to the clinic in the next days. And if Rafael Rosell is over there, I would like him to conclude this special session.
Thank you very much, Antonio. For me, it's a privilege to close this session. Dear colleagues and guests, they are invited speakers. It has been, I believe, for our colleagues here in Spain, a privilege to have you, to listen to you, in spite of the fact that we presume that the majority of our colleagues in Spain know very well the cutting edge on clinical trials in the plethora of studies in immunotherapy. I repeat, on behalf of my colleagues in Spain, a warm welcome to this meeting. Thank you very much, and I hope that my colleagues can join you in some of the forthcoming meetings. That has been commented by Antonio Calle, that could be not virtual, as well in the real world, as we are talking on the real world of immunotherapy. Marina, has been a privilege to listen to you and also to discern what could be the role of PD-L1, CTLA-4. Of course, a giant, colossal scientist, clinical scientist, Roy Hers. Jordi has been also amazing to follow you. I have to confess that I was not able to follow the rim of your slides. And finally, Dr. Jürgen Wolf, Professor Jürgen Wolf, also very fresh, very clear, and also there are many questions. And I'm sorry because I see that in the chat that there is one person in the audience that have some point to raise. Maybe Antonio, you can just identify the person that is in the chat, that then you can later on connect with the person or the speaker or the questionnaire. Well, sorry for so blah, blah, blah. Thank you very much, all of you. Thank you very much. See you soon. Bye.
Bye.
Thank you very much.
Bye. Antonio, dear colleagues, thank you very much, Antonio.
Muchas gracias, Rafael. Muchas gracias por tus comentarios finales. Y nada más, dar por finalizada esta primera sesión. Ahora hay momento para el descanso café y en unos minutos volveremos ya con la siguiente ronda de presentaciones. Habrá un networking break aquí afuera y os esperamos de vuelta a las 18 horas, a las 6 de la tarde. Muchas gracias.